program. And it's my pleasure to introduce for you Dr. Ahmed Ebada. Ahmed Ebada Salim. Dr. Ahmed Ebada is one of our candidates, our colleague in the department. He is a lecturer of radiology at the University of Alexandria School of Medicine. Ahmed is also a clinical assistant professor at the University of Utah, Salt Lake City of the United States. Dr. Ahmed serves as the educational lead for nuclear medicine section at the University of Utah. Dr. Ahmed provides full-time clinical coverage in all diagnostic and therapeutic nuclear medicine application. Dr. Ahmed research focusing on the oncology imaging using PET-CT in the characterization and therapeutic assessment of hematological malignancies. It's my pleasure to introduce to you Dr. Ahmed Ebada. Dr. Ahmed, please. He will present for us introduction to PET-CT basic and future updates.
Thank you so
Ahmed.
much, Dr. Adam. Thank you. So today I'm going to talk about introduction to PET-CT, understanding the basics, goals and objectives to discuss the most common clinical indications for PET-CT, physical properties and intracellular kinetics for PET tracers, patient preparation, patient protocol, radiation dose, exposure, common PET-CT artifacts, and FDA-approved non-FDG tracers. This is the agenda for today. So PET-CT has significantly expanded in clinical practice and research, specifically in the field of oncology. Fused PET-CT imaging combines PET and CT, so it offers information about the physiology and the anatomy of the tumor. The most commonly used tracer is FDG, which is a glucose analog. Commonly FDA-approved indications in oncology field, it is used for tumor evaluation, detection of unknown primary presenting with diffuse metastatic disease, assessment of treatment response after chemo or radiation, surveillance of symptomatic patients with concern for recurrent disease. It can be used also in non-oncology field, including lung nodule evaluation, neuroimaging, cardiac inflammation such as sarcoidosis, and infection and inflammatory process, as Dr. Morton will discuss later. So fluorine 18 is a PET tracer, which is labeled to the fluorodeoxyglucose, which is a glucose analog. It does undergo radioactive decay within the body to oxygen, more stable form, producing a positron, which interacts within the tissue with an electron, producing two 511 kilo electron volt photons, which is detected by the camera. As you said, FDG is a glucose analog, so it resembles glucose and is actively uptaken by the GLUT receptor type 1, undergoes phosphorylation within the normal as well as tumor cell. However, it gets trapped in the phosphorylated form, and it does not undergo metabolism into the Krebs cycle as glucose. Tumor cells display most tumor cells will display high concentration of hexokinase enzyme, and that's why most tumor cells will display increased FDG avidity. Some cancers may have hexokinase mutation or have low hexokinase, and yet will not be avid on FDG, such as hepatocellular carcinomas, as an example. This is a normal biodistribution of the FDG. Prominent physiologic uptake will be within the brain, moderate uptake within the liver and bone marrow. Heart uptake is variable and depends on the insulin uptake. Physiologic excretion is through the kidneys and urinary bladder. And again, the uptake depends on the concentration of the hexokinase phosphatase ratio, which is highly expressed in most cancer cells, as we said, the hexokinase enzyme. Patient preparation is very important to optimize the sensitivity of the scan. So patients need to be fasting and have a strict blood glucose level below 250 because glucose will compete with FDG, and this will alter the distribution of the tracer. Diabetic patients need also to have an adequate insulin and hypoglycemic agent Usually short insulin needs to be stopped 2 to 4 hours before the exam. Hypoglycemic agents such as metmorphine needs to be stopped 48 hours before the exam. Patients need to be hydrated and void before the exam to limit bladder activity. Patients need to be in a quiet room and avoid talking, chewing gum, or strenuous exercise to avoid activation of the muscular system. So this is, those are images of different patients. So the first one is a diabetic patient who has endogenous insulin stimulation and avid heart uptake, and basically the insulin within their body is actively taking all the FDG into the muscles, so this can limit your exam sensitivity. This is another patient who is also diabetic but has increased uptake within the bowel due to metformin uptake. Patients need to stop the metformin 48 hours before the exam. This is another patient. This is the MEP. This is the fused PET-CT image of the patient with history of COPD. And as you can see, there's activation of the crura of the diaphragm, intercostal muscles, scalene muscles, intercostal muscles. So this patient had increased respiratory effort due to background COPD. This is a patient who was chewing gum before the exam. So he has activation of the masseter muscles. And this is those are two patients who were in the gym the day before the exam. So the first one was biking and the other one was lifting. And you can see uptake related to the biceps muscles. So definitely strenuous exercise needs to be stopped before the exam. Brown fat can be reactivated, and it's rich in mitochondria and can display a lot of uptake. As you can see, typical distribution will be in the bilateral lower neck, supraclavicular region, paravertebral, and in extensive brown fat reactivation, you can see the brown fat surrounding the perionephric region. So patients need to be in a warm room. They may need to be provided with a warm blanket to avoid brown fat reactivation if it's so severe. And you know that based on their baseline PET-CT, patients may need to be medicated with benzodiazepine or beta blockers to block the brown fat activation, which is usually highly innervated by the sympathetic nervous system. This is another form of brown fat activation. It's called a lipomatous hypertrophy. It's typical within the interatrial septum, and it's usually due to just fat sitting in this area, and this can be a source of pitfall. This patient was actively breastfeeding, and you can see that there's increased activity related to the breast tissue. Usually we recommend patients not to continue breastfeeding for 1 day, 24 hours after the exam. Despite the fluorine 18 is not actively excreted into the milk, but given that the tissue is super hot and has a lot of FDG trapped within the glands, this can be a source of radiation to the infant or the baby if she's breastfeeding. So we recommend not breastfeeding for 24 hours after the exam. Factors that may alter PET-CT in cancer patients, we usually recommend having the PET-CT 3 weeks after the first or any number of chemotherapy cycles. If PET-CT was obtained before that, this can be a source of pitfall due to post-chemotherapy induced inflammation, which can mimic residual disease. So we recommend waiting for 3 weeks for chemotherapy, 4 weeks for surgery, 3 months for radiation. If patient is getting a GSF for anemia or in hematologic malignancies, we require that they wait for 1 week because it can lead to marrow stimulation, and marrow stimulation can hide underlying lesions within the bone. As we said, the breastfeeding, 12 to 24 hours. Insulin, depending on the type of insulin, whether it's short or acting, needs to be spaced before the exam. And metformin, because metformin does stimulate the GLUT2 receptor, and it will lead to reflux of FDG into the intestinal cells. So patients need to stop their metformin before the exam. Dose activity, usually the dose ranges from 7 to 25. FDG is injected intravenously. Imaging is done 45 to 60 minutes after the exam. Some studies suggest that waiting for 120 minutes can enhance your tumor background ratio because most tumors have a higher hexokinase compared to the normal tissue cells, so it will have higher uptake compared to the background. It's preferable to administer the injection via a peripheral line and avoid any ports or indwelling catheter because you can get a uptake sitting in the port, and this can be source of a pitfall. When evaluating axillary nodes or supraclav lymph nodes, in a known breast cancer or GI malignancy, it's better to inject on the other side of the pathology because activity related to the IV or FDG can mask underlying nodal adenopathy. Radiation exposure, 2/3 of the radiation is derived from the PET-CT component, from the CT component. The effective typical dose from eyes to eye is almost 4.6 to 5.3 millisievert. Again, it depends on what type of protocol you're using, whether you're using a low-dose CT, a moderate-dose CT, or high-dose CT. We usually use a high-dose CT for dedicated CT of the head and neck and brain malignancies. Low-dose CT is usually used for cases of, for pediatric cases. And the use of IV and oral contrast is institutional preference, and also it depends on the type of cancer being imaged. So in general, an eyes to eye scan is adequate for most types of cancers. If you're dealing with melanoma or a type of cancer that does spread to the distal bones or skin, you may need to get a top of head through feet. In CNS or head and neck malignancies, you may need to get, we actually recommend getting a dedicated PET-CT of this region. Standardized uptake value is a way to assess metabolic activity within the tumor. It depends on the radioactivity concentration measured by the scanner within the region of interest. It does take, in fact, it does take in consideration the decay of the tracer injected as well as the weight of the patient. The use as SUV is now a commonplace in clinical practice. There are different SUVs that can be used, including SUV max, SUV mean, and SUV peak. Different factors can affect SUV, including biologic factors and technologic factors. Biologic factors include the dose of the FDG you gave. It also depends on the blood glucose level. So if patient has a high blood glucose, this will affect your SUV measurements. So if the technologists call you and ask you whether we need to do the exam or not, usually blood glucose level above 250, below 250 will be safe. Above than that can affect your scan sensitivity. Fat and muscle proportion, body weight, respiratory motion, and lesion location. Technologic factors including the scan time, whether a patient had to wait 60 minutes or 120 minutes. If we use oral on IV contrast, this has a minimal effect, but it does affect the SUV values. Interscanner variability, as well as the protocol used, whether it's a high dose or medium dose or low dose CT. A couple of recommendations to unify the SUV measurements. Whenever possible, try to get the baseline and the follow-up on the same scanner. Measure any residual activity in the syringe and injection line to determine the exact administered dose. So even if you know you're injecting 10 millicuries or 15 millicuries, you need to measure the activity after the injection to know what exactly went into the body. Minimum uptake of 60 minutes, but as we said, we can wait until 90 minutes or 120 minutes to enhance the tumor background ratio. Maintain the same acquisition technique and reconstruction parameters, including the 2D, 3D, field of view, as well as if you used IV or oral contrast. Weight the patient every time, and this is very important because most oncology patients may lose weight during their chemotherapy and radiation, so don't just take it for granted that their weight is the same. You need to weigh the patient every time before imaging the patient. PET-CT artifact, the fusion of PET-CT and CT can lead to artifact because both scans are not acquired simultaneously. They are usually acquired at a different time, like an hour apart or half an hour apart. So it's crucial to review both CT and non-attenuation corrected images because misregistration may occur due to patient motion, due to respiration, as an example. So examination of the non-attenuated corrected image, which is very important, can show significant decrease in activity related to artifact. So this is a patient who was being followed up for myeloma. You can see multiple compression deformities, multi-level kyphoplasty, and there's uptake related to the kyphoplasty material. In a myeloma patient, I would be concerned about active residual disease or active disease related to the kyphoplasty material. So looking on the corrected image, I see the superior pole of the kidney. Here's the tracer excreted in the kidney, and I see the kyphoplasty material. Checking the non-corrected images, I still see the activity within the kidney, but there's no uptake related to the kyphi material. So this is a correction artifact due to high density material. This is another patient who had segment focal lesion in the liver, and they had surgery, and this is the surgical clips. You can see on the attenuated corrected images here, you see there's uptake related to the clips, and then checking the non-attenuated corrected image, you see that the activity has significantly dropped. The way to tell attenuated from non-attenuated is by looking at the skin. Usually in non-attenuated images, you will see increased uptake because of the photons are hitting the detectors easily without any attenuation connected to the, compared to the attenuated corrected images. So always look at the attenuated and versus non-attenuated if you're concerned about artifact like this. There are other commonly FDA-approved non-FDG tracers, including the PSMA, prosthetic specific membrane antigen. This could be labeled to either fluorine-18 or gallium-68. I know Dr. Morton prefers to use the fluorine-18 because it has a lower energy, positron energy, so it does affect the resolution, so it has a higher resolution compared to the gallium-68. But we can image the PSMA labeling either with fluorine-18 or gallium-68. Fluciclovine, labeled with fluorine-18, was used for prostate cancer. Nowadays, it has been replaced by PSMA. You can use the dotatate, either copper-64 or gallium-68, to image for neuroendocrine tumors. You can also use sodium fluoride to image bone tumors. I would say nowadays we use MDP, methylene diphosphate, for bone scans. It kind of offers the information that you need at a lower radiation exposure. So PET-CT for fluorine-18 sodium fluoride has a lot of radiation exposure compared to bone scans. So nowadays it is only used if you have a question that is not answered by bone scan. Other tracers, including the fluoroestradiol, the flumetamol for Alzheimer's disease, and other research tracers such as the fluorosimidine and the femzo for the tumor hypoxia. Dotatate, this is a MIP image showing the normal distribution of the dotatate. So you can see that there's uptake related to the pituitary gland, a lot of uptake in the spleen and the kidneys. You can definitely tell that there's no brain activity as in FDG. The mechanism of action, it does binds to the somatostatin receptors, specifically type 2A and type 5, which are highly expressed in gastroenteropancreatic neuroendocrine tumors. Can also be expressed in bronchial carcinoids, paragangliomas, and medullary thyroid cancers. Patient preparation is different than FDG because it's not a glucose analog. So patient needs to space their octreotide. They need to space their somatostatin analog. The short-acting somatostatin analog needs to be stopped 24 hours before the exam. The long-acting one needs to be stopped 3 to 4 weeks before the exam because it can interfere with our tracer. Fluciclovine, as I said, has been replaced now by the prosthetic specific membrane antigen PSMA. However, it was used for imaging of prostate cancer. It's an amino acid analog, so it does go to the liver and the pancreas and the muscles. We usually image early, 4 minutes, compared to 60 minutes in FDG. And the reason is, if you waited long, what will happen that most of your tracer will end up into the muscles. Also, you scan the patient from the pelvis to the head, compared to the FDG where you scan from top to bottom. And the reason, again, is you want to maximize the uptake within the prostate compared to the muscles. Fluoroestradiol is FDA approved to image estrogen receptor positive breast cancer as well as ovarian cancers. It could image better the lobular breast cancer, as Dr. Covington was talking today in the workshop. Mechanism of action, it binds to the tumors with high expression of the estradiol or estrogen receptors. Normal biodistribution, as you can see that there is uptake related to the injection sites as well as in the liver and the bowel. Patient may need to get a fatty meal just to enhance the excretion from the liver parenchyma. PSMA, it has been recently approved by the FDA for initial assessment and extent of disease of high aggressive prostate cancer, including Gleason score 4+3. can also be used to answer a problem if there is concern for biochemical recurrence with rising PSA after definitive therapy with negative imaging on MRI and CT. We can also get a PSMA before treating the patient with Pluvicto, as Dr. Fine will talk about this. Mechanism of action, it does bind to the prostatic specific membrane antigen. Usually there is a lot of uptake in the salivary glands. PSMA can also be used to image salivary gland cancers. So even though there's a lot of uptake, you also need to look for any incidental findings such as salivary gland cancers, which can be PSMA avid as well. Patient preparation, usually patients need to be well hydrated, and you need to check for their anti-deprivation therapy because this may affect your scan sensitivity. Sodium fluoride, as we said, there's no developed criteria for its usage. Nowadays, we use bone scan instead of the sodium fluoride because it has a lot of radiation exposure. The energy level for the sodium fluoride is 511 kilo electron volt compared to the MDP, which has 140. So that's almost like 4 times the radiation exposure. So nowadays, we use bone scan than sodium fluoride. But sodium fluoride, I would say, has a higher sensitivity than MDP. However, it comes at a cost with a less specificity because you can get a lot of uptake related to degeneration within the joints as well as osteoblastic metastasis. Patient preparation, oral hydration, and patient needs to be voiding before the exam because it's uptaken by the bones as we see and is actively excreted into the kidney and urine bladder. Thank you so much.
Thank you, Dr. Ahmed. I think a discussion will be at the end of the session. In inflammatory diseases. Okay, thank you.